So now we're going to spend a decent amount of time on colon polyps and colon cancer. I promise once we get through this, the other 4 sections go pretty quickly. So a colon polyp is just a growth of colonic tissue into the lumen. It's kind of like the opposite of diverticulosis in some ways, in the sense that it grows inward instead of out. Most of these polyps are benign, but you have to remember some are pre-malignant. It usually presents asymptomatic. It's often just caught on a screening colonoscopy. But sometimes larger polyps can cause bleeds or obstructive symptoms. And so if this is our lumen, this is what some polyps might look like, just popping out into the lumen. So there's a few different ways to categorize these polyps. You can categorize them based on what you see on a colonoscopy, and that could be pedunculated or sessile. You could also categorize them by what you see under the microscope. So you can get hyperplastic polyps, adenomatous polyps, and of the adenomatous polyps, you can have a tubular polyp or a villus polyp or a tubulovillus. So there's a few different ways to categorize them. And I want to break this down to make it easy for you to understand. So if we start with the colonoscopy findings, let's talk about what a pedunculated polyp looks like versus a sessile polyp. So a pedunculated polyp is just a polyp that has attached to a stalk. So you can see the stalk on colonoscopy. Whereas a sessile polyp has more of a broad attachment to the colon where you don't get that fine stalk that attaches the polyp into their lumen. So if we look at the lumen here, a pedunculated polyp would look like this because it's attached to this nice stalk here. It's very easily to understand where it's protruding out from the colonic wall. The problem with sessile polyps is that they have this broader attachment that kind of attaches like this. And this is actually a risk factor because sometimes you'll remove this sessile polyp, but you're not really sure if you got it all. And if it's pre-malignant, it could increase your colon cancer risk. So that's why having a sessile polyp in of itself is a risk factor for colon cancer. So let's talk about what you find under a microscope now. So if you have a polyp and you biopsy it, you can get one of 2 things. You can either get a hyperplastic polyp or you can get an adenoma. So hyperplastic polyps are very common, and fortunately they're benign. They're not even pre-malignant, completely benign. They have something called a serrated histology or a sawtooth histology. So here is a benign hyperplastic polyp. Just remember that serrated is a sawtooth pattern, and you can kind of see that here, the sawtooth pattern as I've drawn in. Now let's talk about adenomas because this is more often tested. Adenomas themselves are benign, but they can be pre-malignant through the Adenoma-Carcinoma Sequence that we'll talk about in a little bit. I guess we'll talk about it right now. The Adenoma-Carcinoma Sequence we'll go over. What I want you to know with adenomas is that there are 2 subtypes of adenomas. There are tubular adenomas and villus adenomas. So tubular adenomas are the most common type of adenoma, and I'll have a picture of it here, which actually shows both subtypes, to be honest with you. So it's our most common type, and as the name suggests, it's composed of tubules. So in this region here, you can see all these little tubes, all these little circular structures. These are tubules. So that's actually a tubular adenoma. I just want to point out that this polyp is probably tubulovillus because there is actually a villus portion right here. And we'll talk about what the villus looks like. The finger-like projection here typifies a villus adenoma. So villus adenomas are more often sessile, which again is even a worse risk factor, and they have the highest risk of developing malignancy. And we remember that because villus adenomas are the villains because they're causing cancer. So here's a picture of a villus adenoma. Villus just means you'll see finger-like projections like this right here, boom, boom. I always think of this guy. I don't know if anybody's ever seen Osmosis Jones, but this is the villain. This is Thrax, Anthrax guy. He's got this long nail here, and I just remind, if I ever see Thrax's long nails here, I know that's a villus adenoma. Before we talk about colon cancer, I want to talk about a few more polyps that are often tested, and those subtypes are called juvenile polyps. So a juvenile polyp is a hamartomatous polyp. What the heck does that mean? So a hamartoma is a mostly benign collection of cells. So it's mostly benign, but it can be cancerous. And you'll see juvenile polyps in two different syndromes, either juvenile polyposis syndrome and Peutz-Jeghers. Let's start with juvenile polyposis syndrome. This is an autosomal dominant disorder. And as the name suggests, you get multiple juvenile polyps, usually found in the rectum. And so because of all these polyps, your presentation is going to include painless rectal bleeding. And because they're mostly benign, but do have some malignant potential, this does increase your cancer risk. So you have to get surveillance colonoscopies. I think of these, the more high yield disorder is this Peutz-Jeghers syndrome, also an autosomal dominant disorder, also causes hamartomatous polyps, but this one can cause it throughout the GI tract. A big thing they like to test is that it also has this thing called hyperpigmented macules. So if I go here to Peutz-Jeghers syndrome, you're going to see a few things. The first thing you'll see is this hamartomatous polyp throughout the GI tract. And this is a hamartoma. I think this is a lung hamartoma, actually, but I just want you to know it's just like this ball of cells that is usually benign but can be cancerous. But what they like in Peutz-Jeghers, they love this hyperpigmented macule. So hyperpigmented just means dark, and a macule is just a non-elevated small area of skin. So it's not a raised area. It's just these small dark areas on your lips. And how I remember Peutz-Jeghers causing this specifically, I always think about people who have Peutz-Jeghers look like they put Jaeger on their lips. So Jaeger, if you don't know, is an alcoholic drink that's really, really dark in color. So I just think, okay, these people just smeared some Jaeger on their lips and Peutz-Jeghers. And as we just talked about, all these hamartomatous polyps do have malignant potential, so there's an increased cancer risk here. Now let's move on to colon cancer. Colon cancer is the third most common cancer if we exclude skin. It's the third most deadly cancer as well. There's an incidence, a peak in their 60s, so it's a cancer of older adults generally. How this presents, oftentimes it's asymptomatic, which is one of the reasons why we do those cancer screens and polyp screens, actually. Presents with GI bleeding, especially in the right side. So if you ever have a patient who's having some iron deficiency anemia in the elderly, you have to assume it's colon cancer until you can prove otherwise, because it's so common in that age group. You can also get bowel obstruction symptoms, especially with left-sided tumors. We kind of went into this a little bit with the anatomy section. It's because on your left side, your stool is more well-formed and you have a lower diameter, so it's more likely to cause obstruction on that side. You need to know both pathways from which colon cancer can arise, okay? There's the Adenoma-Carcinoma Sequence, which I've alluded to a little bit in the polyp section. And there's also something called the Microsatellite Instability pathway, or the MSI pathway. Let's talk about the Adenoma-Carcinoma Sequence first. Here's from our colon polyp histology slide. I told you that some adenomas are able to progress to carcinoma through this sequence. So how does this sequence work? So first off, you have a normal colon. Then something happens, some mutation happens that causes this abnormal colon. But nothing happens yet. There's not even a polyp that forms. It just increases your risk a little bit. Another mutation can happen that actually forms the polyp itself. which again is not cancerous yet. But the problem is another mutation can finally come and change that polyp, the adenoma, into a carcinoma. So you can see there's three different things that kind of happen here to go from normal colon all the way to a carcinoma. So what are those things? Well, the first mutation that happens is an APC mutation in chromosome 5. And this can increase your risk of polyp formation. The second mutation that'll happen is something called a KRAS mutation, which will, if you have a KRAS mutation at this site, you'll end up forming an adenoma. Finally, that adenoma can transform into a carcinoma through a p53 mutation, as well as increased COX-2 expression to form carcinoma. A good mnemonic for this is instead of the common firearm, the AK-47, you can think of the AK-53, and which will tell you the mutations that happen in the order of APC, KRAS, and then your guardian of the genome, P53. Another thing they sometimes mention is that aspirin can decrease the risk of colon cancer because, as you can see right here, progressing from adenoma to carcinoma requires excessive COX-2 expression, and aspirin can inhibit that. I'm going to talk about some hereditary syndromes that can cause colon cancer. There's two hereditary syndromes we need to know, FAP and Lynch syndrome. So we'll start with FAP. So familial adenomatous polyposis is a germline mutation of one of those APC genes that we just saw earlier. So right here, you notice if we have this APC mutation already in play, it'll increase your risk of colon cancer because you're already one step ahead of the game. Something I want to point out here that I haven't got to talk about in the other lectures yet is the theory of the double hit hypothesis. So the double hit hypothesis states that both alleles must be damaged in order to create a mutation. So in a normal person, we have two alleles. It's kind of hard to get a mutation in one specific area because, well, actually, and then here's the alleles for FAP. Going back to a normal mutation here. Oh, I guess I do that in the opposite way. Never mind. Okay. So starting with FAP, it already has one germline mutation of the APC. And so now what I've been trying to talk about for the last 30 seconds is that in normal individuals here, in order to get this mutation to occur, you need to have a random mutation in this, which is, let's just say like a 1 in a million chance, okay? And then you also have to have another mutation in that same allele, in that same region. So it's like a 1 in a million chance squared almost, right? Very unlikely to happen. And in FAP though, because every cell in your body already has this mutation, it's a near certainty that one of your cells at least is going to have this mutation here. Because it's no longer 1 in a million squared. Sure, it's still a 1 in a million chance, but you have millions of cells anyway, so it's going to happen. So that's why in these hereditary conditions where you already lose one of your APC genes, you're at super high risk of progressing to cancer. And in fact, in FAP, the risk is so high that you'll get thousands of polyps developing, and you basically have 100% chance of getting colon cancer, just because of that one germline mutation. And so to treat this, you have to remove the colon, and you should do it as soon as it's, deemed a decent time. As soon as you're deemed a decent surgical candidate, it's reasonable to do it because of your extremely high risk. There's some syndromes that they sometimes test, so I'm just going to mention it here. And there's something called Gardner syndrome, which is where you get FAP, and then you get fibromas, and you get which is just connective tissue balls. You can get osteomas, which are bone, like little balls of bone tissue, and then you can get cysts on your skin. And I like to remember this when I think of Gardners. I think of them just kind of getting down and dirty, and working hard, and then they end up with all these sores on their hands. And that's kind of what happens in Gardner syndrome. You get bumps everywhere. You get polyps, you get skin tissue cysts, bone cysts, whatever. The other FAP syndrome they sometimes test is Turcotte syndrome, which is FAP plus CNS tumors. And I remember Turcotte, I think of turban, to remind me that it's some sort of head pathology associated with FAP. Now that we've drilled the Adenoma-Carcinoma sequence into your head, we can talk about the MSI pathway. So microsatellite instability pathway is a totally different pathway. Everything I just talked about, I want you to forget, because this has nothing to do with polyp formation and kind of having that nice progression. This is just a completely different pathway. So microsatellites are repeating sequences of non-coding DNA. So they might look something like that, okay? DNA mismatch repair enzymes are important to know because these can fix mismatched base pairs when they replicate. So let's say you have an AC that, that adenine should not bind to thymine. So this mismatch repair can say, wait a second, let me fix that. And it'll fix it. If you have defective mismatch repair enzymes, that can ultimately lead to microsatellite instability. And microsatellite instability is basically just stating that you have increased numbers of microsatellites during cellular division. So on the right here, if you don't have your MMR enzyme, what's going to happen is that you have these elongating chains of microsatellites. I don't know why I can't speak right now. And when you have these elongating chains of microsatellites and you have defective mismatch repair enzymes, it can ultimately lead to cancer. And this cancer does not arise from a polyp like our previous one. It just arises out of thin air. So Lynch syndrome is an inherited DNA mismatch repair enzyme mutation. So just as FAP was like our germline APC mutation, this is our germline mismatch repair enzyme mutation. And so if you have defective MMR enzymes, you're going to get microsatellite instability and you're going to ultimately have colon cancer. And again, I just keep wanting to reiterate, you do not get that adenoma first. It's just the colon cancer just pops up. Sometimes you'll hear this referred to as HNPCC or hereditary non-polyposis colon cancer. Again, just kind of emphasizing that there's no polyps in Lynch syndrome. You're going to see on tests, even for FAP, I should have mentioned, they'll always give you a significant family cancer history if they want you to kind of go along the lines of some rare genetic syndrome. It's usually on the right side more than the left. People with Lynch syndrome have an 80% chance of being diagnosed with colon cancer. And unfortunately, they have other risks of cancers as well in their endometrium, ovaries, stomach, and other cancers locations. The last thing I want to mention with colon cancer is a few different things here. We'll start with metastases. So most colon cancer, the first thing it likes to do is spread to the liver. And that kind of applies to the entire GI tract. And if we look at the blood flow here, moving from left to right, we have our portal veins that drain into our liver, right? So, and this drains into our hepatic vein and ultimately out to the IVC. So what drains into the portal veins in the first place is our GI tract. So if you had some sort of cancer and you wanted to release little cancer cells throughout your body, it would first go to the portal vein and then it would end up in the liver. And this is from our liver section, which comes up later on. You can see that right here, the GI tract is the most common primary cancer site for liver metastases. And oftentimes they'll ask you a question like this, where they basically say, hey, this patient comes in, they're not looking well, they got weight loss, abdominal pain, it just sounds kind of cancery. And they'll give you this picture where you have a ton of liver mets here. And they're trying to trick you by hoping you pick hepatocellular carcinoma, but primary liver cancer would not be in this many places. This is most likely going to be colorectal cancer that has spread to the liver. I've touched on laterality a little bit, but I want to emphasize it and kind of give you a good mnemonic so that you never have to worry about this, which left-sided versus right-sided does what. So left-sided tumors, we've talked about this, so I hope you get this one right. The left-sided tumors, because the stool is more well-formed as it nears the end of the GI tract, and your diameter is shorter, you're more prone to obstruction, whereas right-sided tumors are actually more prone to bleeding. The pathogenesis is important. So left-sided tumors often follow that Adenoma-Carcinoma sequence that we discussed first, whereas right-sided tumors are more known with microsatellite instability and Lynch syndrome. I kind of give it away here, but left-sided tumors would be, because it's an Adenoma-Carcinoma sequence, it should make sense that FAP would cause more left-sided tumors, and then Lynch syndrome would cause more right-sided tumors because it's associated with microsatellite instability. My mnemonic here is I always remember that everything on the right has 5 letters in it. So right has 5 letters, bleed has 5 letters, micro has 5 letters, and Lynch has 5 letters. So whenever I'm thinking, well, what is this? Right-sided, left-sided, what's going on? You know, I just remember this, the 5-sided rule, the 5-letter rule. The last thing I want to talk about with colon cancer is colon cancer screening. So who is eligible to get a colonoscopy? A couple guidelines I want you to know. The first one I want you to know is that you should start screening at age 50. A lot of guidelines are starting to say 45. I don't think they'll test you on that middle ground, but it's just an idea. Everybody should have a screening colonoscopy at age 50. Any patient who has GI bleeding or iron deficiency anemia should get a colonoscopy. Again, this really isn't a screen anymore. Now you're actually trying to, make sure they don't have it. But anybody with iron deficiency anemia, they love to test that. If you see somebody with strep bovis endocarditis, don't forget that's an indication they may have colon cancer. We talked about this earlier though, but basically you just need to know if somebody's had ulcerative colitis for several years, you need to screen them. And something I haven't mentioned yet though, is that if somebody has primary sclerosing cholangitis, which was a complication of UC, you need to get a colonoscopy right away because there's a high likelihood that they've had UC for quite some years now, and it could have spread. It could have basically caused colon cancer already at that point. Another thing I just want to point out is please do not order like CEA levels to screen for colon cancer. It's really not useful for that. It's only useful for known colon cancer, and then you can kind of assess it for recurrence or progression in people who already have colon cancer, but you can't just screen everybody with it. Bad idea. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.